Thank you very much, Ciara, and thanks very much to our witnesses for coming in, and thank you for the information that you've provided. My first question is to Mr. Ryan, and it relates to a question asked earlier by another committee member in relation to the forensic services and the low level of COVID in the forensic services. Am I right in saying the forensic services is one building, or are there additional services throughout the country?
So the Central Mental Hospital is the one building in Dundrum, as you know. We also have Oireachtas Island in the city centre, and obviously our prison in-reach staff go into the main prisons across the country. So as a forensic service, we're national, but the Central Mental Hospital is within one facility in Dundrum. And as you're aware, we also opened a 9-bedded unit as a response to COVID in the new facility, but that has since, we have moved patients on from that since.
Mm-hmm. Yeah, so I'm just when you say the forensic mental health services, it does sound like multiple locations and all the rest of it, and it clearly isn't that. What date did you restrict visitors to the CMH? Obviously, Oireachtas Island would have been closed, I imagine, in the early stages, and then the visitor restrictions to the Central Mental Hospital would have kicked in. What date was that?
So I can't remember exactly. It would have been in line with whatever the recommendations of the public health authorities at the time.
So it was exactly in line with NEFIT. You didn't close ahead of that time.
I don't think we did.
Okay, Mr. Ryan, can I ask you to check that so that you're certain, because that's not my understanding, and you might correspond with me on that. That would be very helpful. I mean, you and I, and I'm sure the other witnesses here are more than familiar with the Central Mental Hospital. It has a massive high wall around it and double gates at the front. So indeed, it's very hard for anyone, or indeed anything, to get in or to get out of it. It's similar to the prison setup. So I just, I wouldn't want the impression to be given that this was a kind of an open facility when clearly it wasn't. With regard to the restarting of care, and my apologies if I've missed this because I have been dipping in and out to the evidence, is there a plan for catch-up on services that have been missed, or people who might require more intensive engagement and more intensive therapy? Is there a plan to catch up? Because we all know, and we've spoken at length about the impact that this pandemic will have on the mental health of the general population, but even more acutely so in those who would have been users of the mental health services.
So I might just start generally, and Dr. Nazi will follow on. We've, the HSE, as you're aware, produced a document on business continuity, which essentially means that we've all looked at our own services from the care groups to look at what do we need to do now to bring services back on stream. So that plan is almost complete, and so what we're trying to do look at is what can we do safely, what can we use some of the technology that we would have already learned about the last couple of months, and also then we need to take into account that potentially what impact there may be for a second surge or a second wave. So Dr. Nazi, you might just...
in relation to the startup of the services, first of all, as I said earlier, that our acute units continue to function 24/7. Our 24-hour residences were open with limitations to visits. The services which were impacted were our day centres, day hospitals, group therapies, group activities. And again, they are gradually starting again with social distancing, with all the guidelines from HSPC that we are following. The COVID has impacted general public, not only mental health, and who do require support from mental health services. So HSE has worked very hard on a psychosocial and mental health needs of general public. And they are targeting carers, they are targeting families, they are targeting even staff who got impact from the COVID-19. So it's a comprehensive national plan that they are rolling out for the general public, for the staff, for the carers. And in relation to the secondary mental health services, as I said, yes, we are starting back slowly and gradually, keeping the guidelines from public health and from HSPC. And I think it depends upon how successfully we manage to control the virus. And I think that will guide us how we will restart.
And in terms of so there's no specific catch-up campaign, as you've said there. Just with regard to the recruitment issues, so we know that in advance of this pandemic, there were serious recruitment and retention issues. We know in part that those were caused by recruitment embargoes imposed by the previous 3 governments, much and all as their members come in and give out about it now. So with regard to the catch-up, which you haven't outlined, the restart of services, which were already understaffed, is there a specific recruitment campaign that you have identified, and do you have a target for the number in each grade group and category that will be necessary? Have you got a target in mind? Is that target published?
So that target has been published as part of our business continuity. What we're looking at is what level of service do we need to bring back in a safe way, and that depends on whether it's inpatient, day programmes or community. So that number, Deputy, will be determined by our business continuity plan, which, as I say, is being worked on at present.
Okay, so you referenced there, Chair, if I could, just one more question. You referenced the use of technology. Now, I have my own opinions about telemedicine, particularly in the area of mental health. I've made those views known. I'm sure you're well aware of them, Mr. Ryan. But I'll just draw your attention to some information provided by the Samaritans, in which they say phone calls, so they're talking about an increase in the number of emails because callers are finding it difficult to talk on the phone in private during the lockdown. So, I mean, this is not an ideal scenario at all, but it was a stopgap. And I would hate to think that that which was a stopgap and not ideal would now somehow replace face-to-face services. But what they say in this, it was part of a presentation, but what they say in this slide is that phone calls appear to centre on a need for human contact. So replacing face-to-face services, even in a socially distant way, replacing those services, it will never, ever be right if they are replaced with telemedicine. I don't believe that has any place, and we can see when those services were replaced with a telemedicine service that the Samaritans are reporting that their calls appear to centre on a need for human contact. So could you provide details for us as to how many of the services are going to be replaced with a telemedicine service, and perhaps if Dr. Niazi could give his own view on whether or not that would be an adequate replacement for face-to-face services. Thank you.
You're absolutely right. When we are sitting with a patient face to face, it's not only the words that a patient says, there is a lot of other things that we look at. We look at their body language, we look at their hygiene, we look at all the other dimensions of our assessment. Secondly, there are patients who even are paranoid, who are not well when they are on the other side of the phone, and because they have their own anxiety about the technology. But it was used in pandemic, and we are not saying that we are replacing it. In fact, even during that pandemic, when the use of technology was happening, if a doctor was concerned about somebody's mental health, or if he felt that the information required from those assessments was not gathered appropriately, they were asking patients to present to the acute units, where separate areas were developed, keeping social distancing, keeping all those guidelines in place. Now, since the pandemic is settling a little bit, those face-to-face assessments have started to increase. As I say, it's patient need that dictates that how much of that can be done by technology. If a patient says that I'm not sleeping and I need a sleeping tablet, yes, we can address that issue. But if we feel that his assessment requires face-to-face detailed assessment, patients are invited in our units, and we are looking at all our outpatient areas, our sector headquarters, looking at their layouts, what needs to be done to make them safe. So I totally accept we are not replacing technology, but that's another arsenal in our tool that if we need to use that, it's available.
Thanks.
Okay.